We're talking tonight about New Frontiers in Public Health. These are the covers of two publications that I've had the honor of participating in. Even though I have worked in the International Labor Office in Geneva, Switzerland as an international civil servant of the United Nations, I have moved a lot away from the workplace health area in particular because the field has shifted, because the organization of work is so different, and because the technologies in life around us also have an impact in the workplace that wasn't really envisioned all those years ago. So just very quickly, so you see the themes for tonight: New Frontiers in Public Health. On the left is the Handbook for Parliamentarians for the Convention for the Prevention of Counterfeit Medicines, called the Metacrime Convention for the Council of Europe. This is a convention that now has 11 ratifying nations, and I'll talk a bit about what that means. And I had the honor of being the lead author, and in some parts of it, the only author. It's an official publication available on the web for free from the Council of Europe in English, Spanish, French, and Russian. And on the right, you see the cover for my new book that will be out in spring of 2018, Global Health Impacts of Nanotechnology Law. As Paul pointed out, I've done a lot of things that led to these things that you saw on the screen just now, and one of the things I'm extremely proud of is I wrote the first doctoral thesis in the law of nanotechnology for the Geneva School of Diplomacy, and that thesis was given the prize for the best research in social medicine and prevention at the University of Lausanne. So first of all, what are we doing here? What is nanomedicine and what is metacrime? These are two words that did not exist, not only when Paul was born or when I was born or when I went to school writing my thesis, but I will submit even when you started school, if you're watching this and you're a college student. These are new words. Nanomedicine is an evolving concept. It's based on using the manipulation of nanoparticles, which exist as a unit of analysis, the tiniest, 53 molecules, 60 molecules, depending on what you're looking at. It's an evolving concept of using what we've learned about nanotechnology to cure health problems, to prevent health problems, and to develop cheaper and much more efficient drug delivery systems. What do I mean by a drug delivery system? Well, if you have an aspirin, you have an active agent. You have a bunch of stuff surrounding that aspirin so that it's digestible, so that it doesn't spoil in shipping, so that it's shipped properly. And what if you could just reduce that to a few little particles that you shoot through a laser? Think of how much money and time you could save, and possibly life-saving time that you could save if you just had a few well-targeted particles that went right to the heart of the problem. The nanoparticles are so small that they can fit between cell walls. The nanoparticles are so small they can actually enter cells and try to kill, for example, a cancer tumor. So nanomedicine is taking what we've learned in nanotechnology, that I will talk about very briefly, and applying it in the medical context: preventive, treatment, curative, and dealing with issues we might not have had before. Metacrime, by contrast, is when you have somebody counterfeiting a medicine. That's a public health threat for a totally different reason, not because the medicine may be bad, of course there's always that risk, but because the system itself cannot regulate and confirm the validity of what's going on in a medicine if it's not the licensed, protected, regulated substance that most medicines you buy, whether generic or over-the-counter or in the prescription format, all of those are really the subject of an enormous amount of surveillance. And so these are also, by the way, really wonderful new areas for major aspects of employment. There are jobs implementing the theories that I'm going to discuss tonight. So I will be very brief in 5 different ways. Part 1, I'm going to describe metacrime, and for that purpose, I am going to remain very wedded to the document that you see and the Council of Europe activities surrounding that document. Then I'm going to talk a little bit about nanomedicine and some of the promises and the exciting things that are supposed to happen. It sounds like Star Trek sometimes when you describe it. Then I want to say, how did we get here? This is where Barnard was very relevant in my life, because Barnard gave me the intellectual playground to take abstract concepts that sounded unrelated and weave them together, and really taught me the skill set that turned out to be incredibly useful in each phase of my career, but especially in dealing with metacrime and nanomedicine. And I want to say very briefly where the jobs are and give you some conclusions. So first of all, you see this little pirate eye patch. This is not my graphic. This is made by the Council of Europe itself. And here we have counterfeit medicine. And we have the launching of this particular convention that was the subject of the Handbook for Parliamentarians, for the people within the Council of Europe elected structure of 850 million Europeans who have the right to go home and say to their government, I want the legislature to do this. This handbook was launched at a very exciting conference in Paris at the OECD, and in fact, we have the minutes of that conference available in PDF and in hard copy tonight. And at this conference, the parliamentarians themselves made a commitment to take on the issue of metacrime and try to get ratifications for their convention. Under Council of Europe law, only 5 ratifications are required for it to enter into effect, which meant that just 6 months after this conference, the convention went into effect. But in fact, right now, we have 11 ratifications. So how would you capture this wave upon the sand of metacrime, assuming that what you're concerned about is keeping the integrity of the public health system intact so that consumers have confidence that what they're buying is actually the medicine they think it is, so that people who are treated with a medicine and have a bad reaction are really reacting to what the government and the healthcare providers believe is the medicine and not some other concoction that purports to be that medicine. Because just think about this. If you treat the wrong thing, you can't really help a person. So if the ingredients are somehow denatured because of the fact that it's a counterfeit, that costs the healthcare system an enormous amount of money, especially in Europe, where most of the countries that are signatory have nationally financed healthcare. If somebody becomes ill after taking a medicine that should help them, there's one of 2 possibilities. One is that there is some individualized reaction, and that person needs other assistance, or it's possible that there's the wrong information, that is believed to be the medicine, but in fact it's a counterfeit. And then you have a very expensive and difficult problem. How big a problem? Well, according to the Council of Europe, using data from Interpol and the World Health Organization, we're looking at $75 billion a year in criminal medicines for human use. I will note that the convention also deals with veterinary medicine, but they have estimated that it's $200 billion a year in lost revenue, plus administrative costs in trying to investigate and prosecute, lost tax revenue, because if you purchase something that's done properly instead of an illegal good, then of course there's a revenue consequence for the nation involved, physical and emotional harm, and long-term economic cost. And some people have theorized that it also helps organize crime, fund terrorism, and acts of terrorism. So this particular photo I showed you, it was really the end of the convention's drafting process and the beginning of this implementation question, where there will be a lot of jobs. How did they define the issue? They said that the problem is looking at the benefits of modern medical technology to be realized while minimizing the risk of harm to the public from fraudulent copies and fake medicines. So they see this as a unique and new global problem. First of all, the scope of the problem has a great deal to do with the fact that globalization is a common aspect of everyday life in all of our economy. Whether you look at the black market economy, the so-called gray market, where things are licensed at a slightly different recipe or a slightly different price than the same things in the so-called white market of high-end products. Globalization means that nothing, whether it's your Mac or your tomatoes, is sold and marketed in exactly the place that it was started. And it's so too with counterfeit medicines. What does that mean? It means that if there's a counterfeit medicine and it's on the market and it's entered the supply chain, it did not come from one place. Perhaps the blisters came from one country and the box came from another, and it was printed in a third, and the actual agent, whether it's a good copy or a bad copy of the agent that makes it active, and the things that surround it for drug delivery, all of those come from different countries. So some of those activities may in fact be legal in the country where those activities are occurring. It's the sum total. It's the putting it together into a counterfeit product that is dangerous to the public health, that is unregulated and unqualified and not monitored through the legal system, through the regulatory system, or through products liability. And the Council of Europe of 47 countries, 800 million constituents, said, what we want to do is we want an international regime. We want something where no matter how many countries are in this process, we have a consistent, coherent policy. We have a method for attacking the problem so that we can really track what's going on. And in this picture, you see the exterior of their building with the flags of the countries and the Council of Ministers, which is separate from the Parliamentary Assembly. They have a Congress, and they also have a conference on international NGOs who have a right to participate in the discussion of any of the issues before the council, and they have a very famous Court of Human Rights. This is an official French publication. I won't labor you with it, but here they state the case for the problem of metacrime as a threat to public health and as an organ for funding terrorism. And they describe the reasons for the urgency of the convention, and France was, in fact, one of the first places to actually ratify the convention. And metacrime, according to the Council of Europe, is a new word invented by the Council to capture the essence of the convention, preventing the creation and sale of counterfeit medicines, false documentation, in other words, the process of saying, hey, this is really what we say it is, could equally be copied just as much as the medicine itself, and oftentimes has to happen in order for someone to accept that false medicine, and also to deal with fake medical devices. This is also from the Council of Europe records. This is the pathway of the trajectory of counterfeit medicine trafficking. And what's important here is how confusing this graph really is. The point of this graph is to show you how confused. The myth, when they started writing the convention, was, well, there are a few key bad actor countries with a lot of people where they can't really afford medicine, and those bad actor countries, if you could just attack their sites for creating counterfeit medicine, you could solve the problem. And when they started really studying the problem carefully, using records from Interpol, using records from various countries that had had problems with counterfeit medicines entering their supply chain, or they've tried to correct the problems. For example, in France, there were women who had had breast cancer, came and testified at the launch, and said that they had been scared because there were counterfeit implants. And the French government, of course, couldn't confirm the health status of those ladies once it was discovered there were counterfeit materials in use. And after careful analysis, you see how confusing it is. It underscores the point that this is not just one nation's problem, that you can't target a bad guy country and say, you fix up your factories and we won't have counterfeit medicines. There are money flows going back and forth through this chain in any number of countries. So the international response before this this convention was not coordinated. There was no single legal force. There were lots of well-intended global agencies, international governance, trying to do things. And Interpol and Europol were very famous for having sting operations. They'd find several million pounds of counterfeit meds in London and then several thousand euros in somewhere else. And the World Customs Organization said, we can't really do much about this. And of course, the World Trade Organization and the World Intellectual Property Organization had no power to really regulate this issue on a global scale. So what's the new approach? The Council of Europe says that this is a global threat to public health that requires an international response. And what they mean by international response is a coordinated effort. They need the key organs to be on board and to use the power under their constitution to attack the problem. The Council of Europe considers itself Europe's democratic conscience. It's a place where health is a human right. We've heard that talked about a lot in human rights quarters all around the globe. And is it a human right or is it? Aren't there times when not everybody is helped equally or fairly in the health domain? Well, not if you belong to the Council of Europe. There is a constitutional right to health in the Council of Europe Human Rights Charter. And protecting human rights on all the levels that are articulated through that charter is the duty of the Parliamentary Assembly, and it's their duty to promote awareness of European identity and greater unity. So these points, woven together, justified the creation of protecting consumer health in a variety of avenues, and here in particular with counterfeit medicines. So the role in protecting consumer health takes a lot of facets. The NGOs have a right to speak. There's a heritage of long-term litigation to protect human rights also. And governments can actually be sued by individuals to enforce these rights. For Medicrime, this is the first time that anyone, as a governmental entity, has called Medicrime a crime under international law. Some nations have some types of Medicrime in some places and not in others. And it's very interesting when you start digging deeper and drilling down. Countries seem to render illegal the things that hurt their economy and not worry very much about the things that either are innocuous or help their economy. But that makes it impossible to do anything about Medicrime unless you have a coordinated effort. So the new law does several international things. It includes an approach requiring international collaboration by experts about the methods. How do you attack this problem? There is in-house in the Council of Europe a quality testing lab for medicines, and it says you can use them or you can use your own, but we need a coherent methodology. Nations, when they ratify, commit to try and harmonize their penal code to reflect whatever it is that's going on internationally. And the really key part here is that there will be coordinated collaborations for enforcement to arrest Medicrime. So if it does go to 5, 6, or 12 jurisdictions, those jurisdictions are on board, that it is a crime in those jurisdictions, that they have reasonably similar approaches to the penal code so that you don't have really, really different character to the penalties involved, and that there's communication between all those countries and all those agencies so that you can really stop the problem. And this just sort of lists for you very briefly the kinds of things that the Committee of Parties has agreed to do. In sum, there is a very, very long list of committees and international collaborations to implement this and make it real. And because it's the Council of Europe, those methods must be transparent. They must be democratic in their nature. They must be subject to comment by NGOs. And if countries don't obey, even the individuals can participate in criticizing. An individual has the right to action in their court. So it's a stakeholder and government partnership, and ratification and implementation requires a massive new infrastructure that is being built as we speak, that in 5 to 10 years will be very, very visible, and in 20 years will be so commonplace we won't even think about it. What does that mean? Well, there are 3 types of ratifying nations. There are nations that already signed off and said, we think this is a great idea, and a very large number of signatory states got this off the ground, a remarkably large number. Then there are countries that have an observer or visiting status within the Council of Europe, and they have the right to be treated as member states with certain rights and protections that are unique to the members of the Council of Europe in concert with each other. And they have the right to be treated with that full way. I just hasten to note that the United States tends not to ratify treaties like this, but it has developed a reciprocal relationship with the Council of Europe in their cybercrime convention, and the Council of Ministers has said that applying that method again with the United States would be welcomed. And then, of course, there are people that may not be part of any of this apparatus, but have a country that's concerned about metacrime, and they too are welcome to sign up. In conclusion, for the first part, the ratifications and implementation has just a few steps, and the President of the Parliamentary Assembly of the Council of Europe has written, I urge national authorities to ratify this important convention without delay. Health and life cannot wait. As an update to that 2015 quote, I will point out that there are now 11 ratifications just 2 years later, which is very unusual for a ratification of an international convention that's so rapid. And that 10 is what triggers the first round of committees of experts and collaborative activities, which means that next year we will see those experts gathering from many nations, not just the ratifying nations, in order to make sub-agreements, in order to try to harmonize laws. There are lots of jobs here with work to do because scientists must be part of this process. The pharmaceutical industry is part of this process. As Madame Chirac, the daughter of the former president of France, said, this is a rare moment where human rights and corporate interests are the same because we want the medicines that are regulated and protected to be reaching the public and not some copy that we can't do anything about. Now, part 2, nanomedicine. Nanomedicine, here's a example of a cell where nanoparticles can actually enter. We used to call this the impermeable or semi-impermeable membrane of a cell, and now we can actually shoot nanoparticles in there and do things to make things different. And as Paul mentioned, my working assumption in all of my work, from the time of my doctoral thesis beginning in 2009 until its fruition in 2014 with the prize from Lausanne, has been that nanotechnology's revolution for commerce will revolutionize public health, and that we in public health and we, the consumers of public health programming, should seize that revolution and participate in the decisions and use that opportunity to set right whatever was wrong with the public health system in the past. Well, if you don't know what I mean by a revolution, the USA today announced that the World Economic Forum had called the fourth round of technology the new revolution. And here from 2008 is a slide from Dr. John Howard, who came to the International Labor Organization when I was teaching there, and when I was coordinating the Encyclopedia of Occupational Health and Safety. Dr. Howard is and was the director of the National Institute of Occupational Safety Health in the United States, which has a budget comparable to the UN agency where he was speaking. And he gave a lecture called Nanotechnology, the Newest Slice of Global Economic Life in 2008, Thanksgiving. So it's almost exactly the anniversary, because next week is Thanksgiving. And he gave me this slide as a present. This slide is a graphic of some of the common marketed items using nanotechnology in 2008. Pharmaceuticals, refrigerator linings for antibacterial nanosilver, pants and clothing, also with nanosilver to prevent rodents and pests from entering. Carbon nanotubes, making tennis balls and tennis rackets all that more responsive. Paints and coatings and tires on famous cars. And also all the technology we see around photography and digital imagery, including medical. And John said to me, Elise, I apologize. This slide is outdated. And he said that in 2008. And he accurately predicted that by 2015, nanotechnology would be $3 trillion of GDP. So it's official. We're in a revolution economically, but the reason that it's really considered a revolution is what it means for science, for the way we look at particles. Now, what does that mean under law? What does that mean for society in the context of medicine? And what does that mean for how law and society and medicine are going to meld together in the decades ahead? Nanotechnology, I tell you, I'm addicted to it. It's fascinating. It brings together so many types of expertise, and that in itself is unprecedented and revolutionary in academia. The amount and type of expertise and transdisciplinary knowledge it requires to put together a strategy or a policy. So this is sort of the context of it. Everything we know about public health is important in nanotechnology. Not only will we have nanomedicines, but we actually have a new way of looking at disease and a new way of treating disease. And I believe, and I will take a couple of minutes to discuss, that nanotechnology is going to transform what we think of as a disabled person or a healthy person. At the same time, it's an emerging technology that gives us new tools and new abilities to see particles and new abilities to manipulate and use those particles that we never had before. And this photograph is from the United Nations Human Rights Council in Geneva, Switzerland. That's the Swiss ambassador. And he was making a comment, and I snapped him. And it's changed the way people are thinking about human rights under law. And it's even changed some of the methods of governance, as you will see. So what's the special stuff about nanotechnology? From a policy standpoint, it's about unknown and unquantified public health concerns. We're doing stuff that we think is a good idea, and we know we're using sometimes innocuous materials like carbon and sometimes dangerous materials like titanium dioxide. And we're finding that sometimes things that we thought were safe, like gold, which is maybe dangerous in a wedding ring if it bonds you to marriage, but otherwise doesn't change very much. Gold, considered one of the most stable things you could work with, is explosive at the nanoparticle level. And we use it even in cell phones in the teeniest, tiniest amount because it creates such marvelous connectivity. So for medicine, when we're looking at devices that may be counterfeited and a subject of the convention I just mentioned, or devices that may be used to counterfeit other types of medicines, when you use it in devices, you can create new responses that are wonderful. Well, how small is that? What are we really talking about? We're talking about something that's so small that if you look at one of the strands of my hair, just one strand, the diameter of a strand of hair is 100,000 nanometers. The diameter. So we're talking about very, very small. To an engineer, that means the challenge is, does the nature of engineered nanostructured materials and devices present new safety and health risks? We use gold in a way that's now potentially dangerous, even though it wasn't before. We use titanium dioxide for skin creams and cosmetics and making whipped cream fluffy when you go to the donut store, and toppings that come out faster from the aerosol can when you're making whipped cream at home. And we think that's great, and maybe it's a new risk. But that's just one slice of it, because the real question is, we've always had nanoparticles. Life is made up of nanoparticles because nanoparticle is a unit of analysis. It refers to the size of the particle, and the particles existed. Even when we create new elements using nanotechnology, the elements are made up of stuff that always existed. So the real generic political question that's very important is how can the benefits of nanotechnology be realized while proactively minimizing the potential risk? And this, of course, is a question we face all the time in public health. This is a perennial question about safety, health, administration of medicine, cost of medical equipment, cost of delivery of care, and deciding who gets treatment and who decides. So I'm going to run very quickly through some slices of national reports about nanotechnology, some of them almost 10 years old, but some of them quite new, just to show you that governments are puzzled. What's unusual here that's important in nanomedicine, if you want to create a strategy and you want to be part of the future of it, either as a consumer or as a nanotechnology, nanomedicine, healthcare participant, or as a strategist, or as a public health planner trying to figure out where to put resources in order to get the maximum benefit to help the population. In all of these cases, what's so fascinating is governments are puzzled. They don't know what to do. The Swiss government expressed a concern that the behaviors of nanoparticles have potential consequences on the ability of synthetic nanomaterial to cause harm in novel ways, ways we never heard about before, that we didn't think about when we were planning. The Royal Commission spent a great deal of time in 2008 for what's considered a watershed report to talk about the fact that we had lots of well-intended mid-20th century medicines like thalidomide and DS. You must remember some of that, right, Paul? We had things that had really catastrophic consequences. So just because we have good intentions and we think we know what we're doing may not make it right. But they threw their hands in the air. They didn't say, and therefore we must do this, that, or the other thing. The US NIOSH, where Dr. Howard is still in charge, talked about the legal basis and justification for recommendations preventing risk of harm from carbon nanotubes and nanofibers in the workplace, bringing me back to workplace health. It's full circle, yes. But they wanted to know whether there was identification, risk estimation, and discussion of health effects, and they couldn't find it at the time. So they had to create a mechanism for recognizing, on the one hand, that what we think is beneficial is already out there in commerce and already happening, but in fact, it may not be good, and what do we do next? And it's very unusual because NIOSH is a research institution. It is not an enforcement authority. It doesn't inspect workplaces. It doesn't promulgate standards. And it's respected internationally as defining sort of the gold standard of what's a recognized hazard and how to do it right. And NIOSH spent a great deal of time and money and effort creating recommendations on how to handle these nano products, which in turn became the precedent for now there are things on titanium dioxide, on nano silver, and other nano products. So the list is really long. And there are plenty of governments that agree with NIOSH, that the risks are unknown, but these are things that really benefit humanity. And so here's the OECD since 2007 has had a working group which NIOSH participates in, but also has a very large party on manufactured nanomaterials. They're beginning now in the last couple of years to really start having a codified guidance. They don't really have the authority to pass standards under their treaty, but they're widely respected, and they work with the NGO, the International Standards Organization. And you're beginning to see scientists, lawyers, policy strategists, policy analysts, and consumer groups working together to come up with an approach. Here's just some of the list of some of the players. So where does nanomedicine fit in that? Well, nanomedicine takes all those very same problems about nanotechnology, that it isn't really the same rules of the game, that it's a revolution from the standpoint of the size of the material changes the way the matter behaves. It changes their physical properties, and it throws them into a place where we have had perennial issues, where we have, for a long time, struggled with cancer and Parkinson's disease and Alzheimer's and bone loss in humans and other species. And nanomedicine says, we think we can do something about this. We think we can shoot nanoparticles into people. We can generate new organs from nanoparticles. We can do things that we weren't able to do before. And this happens at a very interesting moment in history that you really sort of do have to know things about public health and law and nanotechnology at the same time to understand. In 2009, while all these activities were going on in nanotechnology that I described to you, the World Health Organization wrote its first ever report, World Report on Disability. And it remarked that there's a shift in the way the law and society regard disability. That there has been a shift from an individual model that sometimes blames victims for their disability and says, it's your fault. You shouldn't have gone skiing and fallen down and broken your leg. You knew better than to go skiing. And focuses on one or two people who have similar skiing accidents. It's changed from that medical model to a social model, that now there are international and national laws protecting the rights of people with disabilities, requiring accommodations to meet their needs, requiring that jobs be changed in order to meet their needs, that hotels and banks and a whole bunch of places have to do things that are called reasonable accommodations to meet their needs. And suddenly, disability is viewed as something about society's need or lack of need for what's going on in that individual, rather than something in their bodies. At the very same time, we have a revolution in medical care that we have a completely new approach using nanomedicine to approach disability. And at the very same time, we have more data from public health, big data, telling us what happens in disability and illness in ways we never understood before. Nanomedicine makes amazing promises. It promises that we can regenerate bones, that we can have biodegradable stents, that we can prevent the buildup of matter inside the stent because it fades away because of the way we bring the nanoparticles to the medical device. And all of these things taken together are going to be used not just in treatment, but in monitoring, in pre-symptomatic examination of the patient. In Japan, clinical trials started in 2013 for a honeycomb device, a little nanoparticle honeycomb that traps cancer cells and keeps them without letting them grow. Do we know if that means that will really prevent cancer? What we know is that we can trap the cells and they won't grow. We can at least delay something. And that means that if we can screen for that pre-symptomatic cancer and trap those cells, we have a treatment. Well, that's lovely, except what does that mean for these definitions of social model and individual model and how we treat people with disability in society? There's a combination here. Nanomedicine will, at the very same time, change the way we treat, but we're going to need new laws in some cases. Are we going to give those people the same stigma that people with disability had in the first place so that they needed those laws? Are we going to say they're not covered by the laws? We're going to say, if you go for this pre-symptomatic treatment, we're now going to give you the full cloak of protection of everybody who has a disability. That's possible. And what are we going to do when they start getting well? When they recover from things that were previously terminal and not curable? When somebody with Parkinson's or Alzheimer's bottoms out and goes into a very intensive care facility and really needs a lot of help and reaches the moment where the nano treatment comes in, and the nanomedicine gradually makes them healthier and healthier, so that they actually become too functional for the facility they're in, and they're to be discharged somewhere, to the community, to their family, to another institution with lesser levels of care. How do we plan for that? Who's going to do that work? And how will we know we're making the right decision? And what if they want a job? We've never planned before for the revolving door of certain facilities. Certain facilities, we've planned that once you go there, it's a polite way of helping you towards the very end. And in fact, it may be possible for people to leave those and need a placement, and need a home and a job, and continue their lives. And that's cool, but it raises bioethical issues, and it raises a lot of other issues that will require lots and lots of work. So this is just a very quick slide of some of the things that nanomedicine proposes to fix. And the big ticket diseases are being very carefully studied in ETH in Zurich, Switzerland. There is a team that is looking at using human stem cells to make replacement organs for the individual, which means that, for example, the conventions about human trafficking that say we don't want people to have to pay or be kidnapped for their organs if you want a transplant, this will take on a whole different meaning, because it will sort of be outdated just by the idea that you don't need those mechanisms anymore, assuming that we set up the right infrastructure to make it affordable and accessible. But it's totally possible that with technology, we can end the human trafficking of organs. It's 5 to 10 years away that it will be possible. Will we make the choices? Who will have the jobs of dealing with those questions? These are big. It sounds like science fiction, and yet it's purported to be science fact. We know that we can use nanoparticles and nanomedicine to change DNA. Is that considered a manipulation of genetic material under a variety of laws and treaties? Or is it just because we're correcting within the DNA? We're not putting in new genetic material. We're not putting in parts of other chromosomes. We're just making little changes with nanoparticles using proteins we already know about. And this is a list of a variety of websites that are doing, for the World Nano Cancer Day, they offered a list of the various types of diseases that have sites that are up and running, and you can look at them and see the kinds of progress and the kinds of symptoms. And in some countries, these are getting ready for clinical trials on a very small level. So as phantasmagorical as it sounds, these things are becoming quite real. And certainly, either prematurely or with appropriate amount of discussion, these will become commercial and marketable very soon. There's a real push for commercialization, not only because the gravity of the illness involved, and the size of the market for some of these. For example, if you could do something that helped 10% of the people with cancer, that's a huge market. But also because the technology is progressing very rapidly. And so there's an impatience to see the economic benefit from the work that's being done. Well, so the things that happen in nanomedicine is that there are lots of opportunities. We can create new organs. We can have a sharper focus of the technology on cancer cells in particular, a lot of time and money being spent on that, or other disease sites. People are looking at vaccines that will go in and attack the virus, even after it has attacked the human body. Things that can be done to destroy tumors, to selectively hurt part of the illness, whatever it is, to reduce the toxicity of certain types of drugs because we use such a remarkably smaller and more pointed drug delivery. But in fact, if it's really that toxic, a lot of questions around that, and a lot of very careful study that has to be done. And the potential to reduce risk compared to the larger dose is only part of the story, because What about the mechanism for delivering that? Who's going to train the people to use the machines and read the lab reports and make sure that this is all turning out right? There's improved access for outpatients, a very big question about the role of outpatient versus inpatient care, but a clear cost savings. And there are predictions of some remarkably extended survival curves for people with a variety of diseases and reduced economic costs associated with that, especially if they return to productivity. And discussion, this is a comment we made to the project in the National Nanotechnology Initiative of the United States about their desire to have grand projects that capture the public's imagination. So part 3, how did we get here? How much time do I have for part 3? 5 minutes. Okay. Okay, so we're close. First of all, I have to thank Barnard because Barnard gave me the intellectual playground. Barnard let me write a senior scholar's honors thesis about occupational health as a law system. The law of occupational health in the USA, France, at the time Soviet Union, doesn't exist anymore, and under international law, which gave me field work and the opportunity to meet ILO and to see what was going on in other countries. And in that became the blueprint for a great deal of work in occupational itself, as you said. I wrote a treatise for 20 years called Designing an Effective OSHA Compliance Program and updated it every year. But it also introduced me to the importance of the inextricable link between work and health and the survival of greater society, and compelled me to go to Johns Hopkins to study public health. And I was very fortunate when I was teaching at Columbia to look at genetics questions. The natural outgrowth was the thesis that led to nano, because these questions, some of them are perennial, they're just in a new vehicle. And in a revolutionary context of looking at this vehicle looks at them in a totally new way. So what did that mean for jobs? Well, for the future, first of all, of course, the Council of Europe has an enormous need for staff, not only on the legal end and the diplomatic end, but in the hard bench work of figuring out the methods, of assembling the committees of experts that will come up with a consensus method that will globally protect the purity and validity of medicines and prevent the entry into the mainstream of counterfeits, and also will be able to detect them. And we believe, using not only nanotechnologies, but other areas, that that's a very real possibility. There'll be testing, there'll be prosecution for sure. There will be legal teams that will be inventing and implementing things across jurisdictions. It's going to be very exciting. And I have not touched upon the role of patents in intellectual property because it's beyond the scope of the convention, but certainly in parallel, there will be developments there. The convention is very clear that it does not want to touch the intellectual property order, that that's too complicated. If a country says the medicine is legal, that's good enough for the purposes of the convention, but there is a problem that not everything is legal across all the countries, and that has to be dealt elsewhere. And of course, nanosensors and biosensors, which I didn't have time to discuss, will also be used to prevent counterfeits. And this is the web addresses for some European platforms on nanomedicine that will also be involved in some of the implementation in the Council of Europe. Nanomedicine, I think I've said it already at least twice. There are new treatments and there are new specialties that are going to be out there because of that. New methods, training programs. Epidemiology is going to look very different. Survival curves are going to look very different. Plenty of work in bioethics to sort through how to apply these in a meaningful and useful way that's fair, if fairness is our goal. It's true that the human rights community looks at equity, but I'm not sure everybody else does. And that's a political judgment, is it not? So those are societal questions that will have to be sorted out. Some people will argue this is settled under the law, and some people will argue, no, this is so unprecedented and new that we need to look at this. This is a different dimension. It transcends one country. It transcends one disease. And so we have to also ask, are we going to replace or codify the existing prejudices about disability and health that came into play in order to really sort out this question of what disabled people can or cannot do in society, and who's disabled anyway? And does society say, if you can't do this, that, and the other thing, you're not healthy anymore, but in fact, it turns out by some other societal value, you are healthy? We have an increasingly large group of people called healthy disabled, people with permanent long-term disabilities such as neurological impairments in the inability to read, and yet their blood pressure and their heart are fine. They're the healthy disabled. There will be more of them as nanomedicine goes on. Oh, the UN, yes, of course, is working on new laws and methods for implementing. And the UN will definitely be a place for jobs and work, because we already see nanotechnology being discussed in over 100 agencies within the UN in their subwork. So the debate 10 years ago was, should we regulate and should we have laws? And now we've changed the shape of governance. We're seeing lots and lots of transnational programming around nano. We're trying to translate good science into good law and not bad policy. And there's, instead of the old idea, well, maybe we can adapt the laws and maybe we don't need any law because nanoparticles are so unprecedented, we now have an idea that actually we have to modify the law. REACH in Europe, here's one of the working groups from Europe that does nanoreg, is trying not only to coordinate laws across the European Union, but actually write standards, and more importantly, write the methodology for analyzing the nanoparticle behavior to determine in its context, is it safe and healthful, or is it a risk to the public health? Because the context, of course, is so crucial. Think what I said about gold. Gold in the so-called bulk size, the larger size, is actually considered innocuous. And yet, at the nano level, it can be very, very dangerous. It can explode. And yet, in other forms, it's perfectly fine. So context is a player, and this group is concerned, how do you determine what's going on in that context to assess risk? In our own country, the President of the United States, former president, rewrote the Toxic Substances Control Act with the help of Congress. All these people have nice paying jobs, and all of them had to deal with the questions of nanotechnology and where it fits within the Toxic Substances Control Act revised framework. So in conclusion, I can't offer you a recipe or an insurance policy. Anybody could sue anyone at any time for any reason, but transdisciplinary training, thinking carefully about these new technologies and new legal concepts to how we handle technology and global health. This is a lifelong task. Get the best education you can, learn the most in the most variety of subjects. In other words, of course you want to drill down to your expertise. In my core, I'm a jurisprude, I'm a legal scholar. I inherited it from my dad, the lawyer, and I passed it to my son, the lawyer, and it's just the gene and I can't help it. But I know that it's surrounded by a context where one must be cognizant and respectful of other disciplines. And find out the newest and the most information you can about that context, regardless of the subject of your expertise. And be willing to go back to school. When I went to my doctorate, they said, you know, why aren't you teaching here? Don't you know enough? And I said, I don't know enough. But in fact, I got my doctorate just 3 years ago. So you never are totally ready with the tools you have. Be prepared to go back to school and enjoy the thrill of those new questions. And stay tuned. These developments are extremely exciting. Keep informed about the changes in the law. be an active participant in the application of the technologies, not just a consumer and recipient, and enjoy having your say and be part of it. And I thank you for your attention.
Thank you very much.
I just want to point out that this is a flyer for the Safer Nano Design and Law, where I have the honor of being the head of the legal program for May of 2018 in France. If anybody wants to know about it, there's tons more information.